I know it's early this morning after all the parties last night. So welcome to session 73. You do not need a complete EHR, the impact of clinical groupware. I'm Pawan Goyal. I'm the Chief Medical Informatics Officer for Hewlett Packard and a Senior Advisor to US Department of Veterans Affairs. I'm very honored to serve as your moderator today. Before I introduce the speaker, let me remind a few things. First, please do complete your session evaluation. And in every meeting, you are told to switch off your phone. But in this meeting, please do not switch off your phones. Just quiet them. And we encourage you to tweet your questions and comments throughout the presentation. While your questions will be addressed toward the end, but we want you to be active and engaged throughout the presentation. The key for Twitter is pound, HITx, and number 0. It's not O, but the number 0. Let me repeat, it's pound, HITx0. A few fun facts about today's session. This session will give you an introduction to the clinical groupware, what is clinical groupware, and how it's changing the HIT marketplace. A discussion of the platform, application, and modular approach to HIT will be discussed. A few words about our speaker. Steve Adams is the Executive Vice President, Collaborative Care for Alere. He has been the founder and CEO for 4 high technology companies. Steve founded Reach My Doctor and RMD Networks in the fall of 2000. RMD provides collaborative care solutions that enhance healthcare communications and coordination of care among multiple providers and patients, as well as complex healthcare issues. Steve also serves as President and Chairman of Clinical Groupware Collaborative, an industry trade organization dedicated to the development and use of innovative HIT solutions. RMD Networks was acquired by Alere in early 2010, where Steve currently serves as Executive Vice President of Collaborative Care. Now please join me in extending a warm welcome to Steve.
Yo, said the dyslexic rabbi. Oi, said the dyslexic rap artist. Do you think that maybe sometimes we get things backwards in healthcare technology? More on that later. Don't you hate it when speakers go for the audience participation routine? You know, everybody in the room stand up and then sit down if you've done this or haven't done that, and you end up with a few people standing that feel really smart or really stupid, one or the other. Well, I'm not going to do that. What I am going to do is send you a not so subliminal message around collaboration. The term clinical groupware, baked into that at its heart, is a spirit of collaboration. And I tell people when I speak that I have a tattoo that says collaborate or die. Nobody's asked me to show it to them yet, but the idea is that one of the fundamental problems we have in our healthcare system is a lack of collaboration, communication, and coordination of care. We're seeing things like the patient-centered medical home and other initiatives through high tech and so forth that are really beginning to focus on collaboration, coordination of care, and how we can improve coordinated care teams, doctors better connecting with other doctors, patients connecting with their providers, and a coordinated care team. So collaboration is at the heart of part of what we need to change in our healthcare system, not just from the clinical side, but also from the business side. And it's like Bill Murray's quote in Ghostbusters, cats and dogs laying down together. We need to have vendors working together in a collaborative way. So I'm not going to yell collaborate or die when I want to punctuate throughout this presentation. I'm just going to do this. Collaborate or die. You can get that bolt of the spirit of collaboration into your brain when I do that. So, now I'm firing blanks. There we go. Learning objectives. Here's what I hope you learn out of this, and if you don't, then clearly it's a technical problem, not a problem with the speaker. We're going to discuss how the market is adopting modular approaches and what platforms mean, how modularity in platforms and applications are coming together. We're going to talk about how this market is really leading to disruptive innovation. Clay Christensen came up with one of my favorite phrases in disruptive innovation. And here's an important note for you. The same can be said for me. If you think you really got this, you probably need to watch the video after it's available a couple of more times. It's complicated. So here's really the heart of this presentation I can get across in this one diagram. If you take innovation, and by innovation, let me spend a moment on that. I'm not talking about sitting around and dreaming up new ideas. That's an important part of the process. But true innovation is about applying new ideas in the marketplace and actually having them be disruptive. So if you take that kind of innovation, applied innovation, and you combine it with collaboration, all of a sudden you're getting new opportunities. And by new opportunities, I mean opportunities to deliver better care, get better outcomes, save lives, do the right thing in healthcare, and also business opportunities. Opportunities for new businesses to get into the market and grow. And if they do well by doing well, that's what we want to see in business. Big debate, you hear a lot about this now, the walled garden versus the open web. Wired had an article a few months ago that declared the web was dead. And what they were talking about is that there's an increasing move towards not just HTML web pages, but applications that are really running on the internet. I'll give you an example. Last night I was reading a book on my iPad through the Kindle application on my iPad, a book about scuba diving. After 40 years I'm getting recertified for scuba diving. I guess that's my late life crisis instead of buying a sports car. But I'm reading this book on my iPad through a Kindle application, and at the same time I'm listening to some Mozart piano concertos on the iPod functionality on the iPad. Neither one of those were web applications. They're internet-based applications. If you understand the distinction. Now, walled gardens, and I'm going to talk a bit more about that, are where, like the iPhone, where Apple has made that platform available, but only with their rules. Only with their rules can you develop. More on that in a minute. So the internet versus the web. The internet, think of it as the plumbing. It's the hardware, the pipes, the pieces that bring the internet together, that network of networks around the world, where the World Wide Web, as devised by Tim Berners-Lee, is really the code, the construct and the standards that allow for exchange of information running on the internet, and that's HTML. Now there's many new versions of HTML with many new kinds of capabilities, but that's a good summary of the difference between the internet and the web. There's a similar trend, and if you think about the move from basic internet connectivity and moving data to web services that provide information on the web, to applications that are now running on the internet, we're seeing a similar trend in EHR technology. And in that trend, in this shift, which is a very major and important shift in our world of HIT, we're going to see that modularity is a key ingredient and important part of that shift. So look what's happened in the last year. It's really insane to think all the policy that's come into play, all the dollars that are flowing into the market to really facilitate a major change in healthcare technology. One of these is meaningful use. Everybody knows what that term means. And by the way, what a good name. I mean, wasn't it great that somebody sitting around a table at ONC said, let's call it meaningful use, because this is about not just technology, but getting something meaningful out of it. We need to see results. We need to see that it improves care, improves outcomes. So in the process of developing meaningful use, and I like to think that the Clinical Groupware Collaborative, particularly with David Kibbe's help, had significant impact on including modularity as one of the criteria for certification in meaningful use. This means that you can go in and have a certain module or a set of modules certified for use within meaningful use, and it gives the provider the opportunity to choose some best-of-breed modules instead of buying a monolithic system. This is a major shift in the market and a major shift in the way that these applications are going to work. So here's an interesting diagram that kind of illustrates the business ecosystem and the technology architecture. So to the left, you see a closed system. So this is proprietary closed, there's no connectivity, the code is kept secret, there's nothing open about it. If you move up towards the right, where when we end up all the way in the corner, it's more open and collaborative. In the middle is a walled garden, and Apple's a pretty darn good example of that. They just announced that now they're going to charge 30% commission, if you will, for anybody selling an application over their platform, iPhone, iPad, and so forth. But we'll see how that plays out for them. The price just got steeper to participate. But you also play by their rules. In other words, if they choose not to let an application onto their platform, they can do so. So it's in between a completely closed system. When you look at all the developers that are working to develop for Apple on their own, independent developers, it's an incredible phenomenon. Moving up to the right-hand corner is where you get into completely open apps and APIs. And this means that all the code is available to anybody. The open source movement has been around for quite a while. There's been some tremendous successes and some failures in open source. But the movement, the velocity seems to be moving towards that upper right-hand corner where more and more people are willing to let others connect with them in an open way. What's the result of that? Well, this phone fight is a good example. I've got an iPhone. I've bought each version since it came out. I'm one of these crazy over-the-top early adopters, you might have guessed. My son bought an Android, 16-year-old son. He's got the Droid. And we have constant debates about which are best, right? Whichever is best, what has happened is that we have changed the market into something that is truly vibrant and competitive, and we're seeing better technology come out of that competition. We're seeing an arms race, if you will, in cell phone and smartphone technology to one up the other to stay competitive in the marketplace. The result of that is that for consumers, we're getting a lot better phones. So the old way, that bottom left-hand corner, closed and monolithic, proprietary and non-interoperable. I've heard EHR company CEOs say, why would I want to connect with anybody else? I'm opening myself up to competition. That's the old way of thinking. If you look at the new stages of meaningful use, it requires connectivity. It requires the ability to move data from one source to the other. We cannot live with silos in healthcare. Now, those monolithic systems had pretty low volume, but they could charge a lot. And there was quite a revenue opportunity for services ongoing. A lot of customization needed, a lot of user support is needed in that model. But another benefit to the vendor is that there's real high switching costs. Once you get them on your system, chances are you've got them glued in there for life. So what's the other approach? Modularity and disintegration. I'm going to give you an example of the computer industry. So if you look on the left side of this frame, in 1983, there were 4 big players. And that was about it. This was what the computer industry looked like in 1983. Fast forward a couple of decades to 2002, and you'll see how all this specialization happened, and all these different companies became good at different aspects of the computer industry. You might also notice that not all those big companies on the left side made it to the right side. I say I have another tattoo, and that's evolve or die. And this was clearly a situation of evolution. So let's look at the EMR industry. You might look at some of the big vendors that offer heavy EHRs, the monolithic type EHRs. And they provide this functionality, and they do it in an end-to-end way. I mean, very feature-rich, very complex, if you will, but really all the features and capabilities you could ask for in an EHR. What we're seeing the evolution to now is EMR 2.0. And that is this modular approach where you see the vendors on the top, vendors A through G, that may be offering different specific functionality. One might really focus on e-prescribing, another might focus on registry, another might focus on, in the future here, things like social networking and peer support. So we're seeing this specialization being done in a modular approach where a provider or healthcare institution can select what they think is best of breed and plug these things together on a platform that allows interoperability. So the walled garden, I've already mentioned the iPhone example, is where you can control aspects of the content and services. You can control which applications are on it, and they're not all alike. There's many different styles of these walled gardens that some vary to more open and others to more closed. Platforms, so if you use the iPhone analogy again, their iPhone is a platform into which apps plug. Now a critical differential here is when you download an app to your iPhone, that app runs on your iPhone or your iPad. But if you have multiple apps on that, they don't really communicate with each other, do they? They're kind of standalone applications. What you're going to see in the future, both from Apple and in the healthcare world, as we see the evolution of platforms, is that when you plug in these modular applications, you'll have the ability to exchange data between them. So if one is about a patient encounter and you're gathering information for that patient with type 2 diabetes, and another module is a registry that's measuring the care for a population of diabetics, they will be exchanging data. More about that in a minute. So big companies, IBM, Covisint, the AMA, AT&T, and so forth, are putting platforms into the market. And the model that they're building are frankly, semi-open walled gardens. Some are somewhere in between. But they're providing the APIs and the support to facilitate those platforms. And they charge applications to be on the platform with a revenue share. So they want more and more applications to come on board. They want those applications to stay tethered to that network. So it's a mutually beneficial kind of model, platform and application. Others are certainly going to move to a completely open platform. This is very much an evolving market as we're seeing it. I left this slide in from about a year ago that says thanks a billion, because the App Store had 1 billion downloads. Now it's 10 billion. 10 billion downloads for the App Store from Apple. So a pretty vibrant illustration of how successful a network and a platform can be. What's moving all this? What are the drivers? Well, ONC clearly has changed the world of healthcare IT. When they say things like, we believe it'll be common in the near future for certified EHR technology to be assembled from several replaceable and swappable EHR modules, you know they're pushing in this direction. Their willingness to make into policy the modular approach is another tremendous indicator of that. Other drivers include things like the PCAST report, the President's Council of Advisors on Science and Technology. I don't know how many of you have read this. It's ended up being a very controversial 126 or so pages, but it's casting new thoughts into how to connect in healthcare and new ways that can leapfrog us ahead. Things like Google Health and Microsoft, the Clinical Groupware Collaborative, and any number of these other organizations efforts that have come together to really make this change happen towards modularity and more open platforms. It's significant. There's a lot of people working together. HHS and what they've done with meaningful use has put dollars on the table. And they're promoting this kind of change through the policy that they have written. Here's one of the challenges. Data comes from everywhere. Every clinical encounter, whether it's a physician visiting somebody at home, in a hospital, in the clinical setting, at the pharmacy, whatever it may be, data is coming from all directions. And one of the challenges is to have this data flow and be usable in ways that are meaningful in healthcare. So far, we've really taken data, and whether the doctor is using a shoebox or the most sophisticated computerized system out there, the data has not been very usable. Reports are generated that are hard to understand. It's usually a burden on the physician to get the data because then they don't know quite what to do with it, or they get a stack of faxes that they're supposed to respond to. All this data coming at the provider has to happen in a better way, and it has to happen in a collaborative way. People need to work together to have that collaboration be meaningful. Here's an off-the-wall example of data coming in, and I see we're getting tweets in here. This was a Twitter instance where people just in an ad hoc fashion came together in a community. This was last summer in Boulder, Colorado. There were some very significant forest fires with many homes burned and a lot of tragedy. So some hackers put together this Twitter feed that allowed them to identify different instances, whether it was an actual fire there, if it was an evacuation area, if there were shelters, if photos were available. And the firefighters for this, both local and federal, found that this was an incredible tool for them to organize what they're doing and have better intelligence around how to fight this fire. So this is kind of crowdsourcing information, everybody who's out there, and applying it in a way that was very digestible, very visual, very usable by the firefighters. Here's another example. There's a platform out there called ThinkMap. Has anybody ever used Visual Thesaurus? Heard of that? Check it out. It's an incredible application, Visual Thesaurus, and you can pick a word, and when that word comes up, it shows the word visibly, but then it links out to other words that have similar meanings. And if you go to that similar word, it then links out from there. So you get an incredible visual representation of the information about the meaning of these words. That same engine, ThinkMap, has been used in this project by NOAA, and they've taken the Chesapeake Bay ecosystem and all the complex biological data about that ecosystem, fish, fowl, reptilian, everything that lives in this ecosystem, and they've done a way of mapping it so that you can click through and really see how these the organisms interrelate and how they're connected. Think about doing this sort of thing in healthcare. Think about if you're a patient and you had a doctor icon that's your primary care doc, and you clicked on that, and then you saw all the sources of data about your information, and you could click on that and easily navigate through your information. Think about the same for a provider who's working with patients that are multi-morbid situations, and he needs to team with multiple other providers and specialists. Having that kind of visual access to data would be really powerful. Here's an example of modularity. This is within my company, Alere, and we have a very complex company. It's a global company with many, many different products, home monitoring devices, services. And we are finding that we have to do a better job of connecting these different modules within the company. So it's really become applications and platforms that are connecting in. But you'll see on the outside of that pink, we're also connecting in with others. So this is just kind of a subsystem that illustrates modularity of connecting to physicians, patients, providers, and all that data. I think every HIT company probably has a similar diagram and similar challenges on how to get the connectivity to work. Direct, no longer in Indirect, but the Direct project. And this is something that I think is very significant, because ONC has really dictated a set of standards. Not dictated, wrong word. They have collaborated to bring together a diverse group of industry stakeholders to build consensus over a set of standards that allow the movement of data. It's a critical part to solving our healthcare problems. Direct has got that consensus, big companies and small. Nationally now, we have a framework. INHIN was the National Healthcare Information Network. It turned out somebody had trademarked that, so they now just call it Direct. But this thing has got legs. More and more companies are participating. There are very large initiatives around the country where HIEs and IDNs and others are saying we're going to use the Direct standards to develop connected care within our community. How will this play in the marketplace? I think in a big way. I think this is a significant turning point to see Direct actually being adopted in the marketplace. Pricing. This is part of the change. This is part of the evolution that we're seeing right now. And what is happening is that full-featured EHRs, like what MedPlus offers, are charging $150 a month for that EHR. We're also seeing folks like Practice Fusion, through an advertising-based model, are actually providing a full functioning EHR to providers free. We just had a meeting with the Clinical Groupware Collaborative last Friday about their application. Very impressive. Their distribution, the number of users they're getting real traction with this model. So the price point in general is going down. There's no question about that. And part of the reason for that is that applications that can be delivered over the internet can scale and be much less costly. So that's a big evolution that we're seeing here. Another significant point is that EHR vendors can no longer just go toe-to-toe in the marketplace, slug it out bloody knuckle style and see who wins. They're being forced to work together. They have to collaborate, and that's because of the policy that's coming out requires that flow of information work between them. Isolated, siloed, non-connected EHRs are going to be the dinosaurs of the HIT industry. It's going to require collaboration and connectivity, and we're seeing that happen now. So modular and configurable. This was an interesting article from a few weeks ago. Pamela Lewis-Dolan wrote. You can Google it and see the full article. But basically it said, EMRs are not boosting productivity. What's wrong with this picture? And the study shows that even if you buy the technology, if it isn't right for your practice, it's not going to help you much. Now this is kind of a profound revelation. And we're seeing it in the low adoption of EHRs, and we're seeing it in some of the results that providers using EHRs are getting. So, what if, and I'm getting ready to ask you a question here, and we have devices, I'm told, where people can vote in the audience, is that right? Okay. So what if? What if there were no rhetorical questions? That puzzled you all, didn't it? Now, my question is, what if you had a choice between two EHRs? One was reasonably priced, fully function, end-to-end, very, very rich in features and functionality, but it's rigid. You don't really have the ability to modularize it or configure it in a way that will match your workflow as a physician. And the second EHR is fully modular and configurable. So the way you practice medicine, you can say, I want this module, I want it configured in this way to match up with my workflow. But that one costs a little bit more. My question to you is, if you had the choice between that first end-to-end powerful EHR that is rigid and the choice between the second one that is configurable and modular to match your workflow, would you be willing to pay a little bit more for that EHR? Yes or no? Now it's kind of a trick question. So yes, if you're willing to pay more, no if you're not. It's kind of a trick question because in reality, that second one I described is going to be less costly. But I'm trying to get the point across. that because it can be configurable and modular, it actually has more value. It's more usable. It's more adaptable to what a physician's workflow is. So here's the, oh, I missed the polling instructions. So turn on your Wi-Fi setting on your phone, connect to your Wi-Fi network to Sprint Polling, and you will see this setting available in available networks. Select Sprint Polling, open your browser, and you will be automatically directed to HIMSS Polling. So the question again, yes, if you're willing to pay a little bit more for modular configurability. No, if you're not. So challenges of the marketplace, and by golly, we have plenty of them. The lack of collaboration, the fractured approaches, and no unified industry leadership are key. There is so much noise in the HIT marketplace, and it is challenging to keep up with all the policy that changes daily. I mean, the last year in HIT alone has been unlike anything I've seen in my couple of decades in HIT. It is phenomenal to see the amount of change. That is a challenge in itself to keep up with policy standards and how all this works. I'm not going to talk you through each of these boxes, but you can see that there's all these forces that have come together from policy, from technologies that are now available, from companies that are making moves into this marketplace that haven't been there before, and the needs of regional efforts that really pointed to this initiative of forming the Clinical Groupware Collaborative. This is a blog post that David Kibbe did, I don't know, a couple of years ago that said something to the end of the next big thing in HIT is Clinical Groupware. So this organization was founded, came together, and it's focused on doing 3 different areas of work. One is market development. We're really developing.
And your answer is yes.
My answer is what?
Yes.
My answer is yes. Oh yes, we have an answer. The poll is out. Yes, people would be willing to pay a little more. Now that's good news, particularly since it really will cost a little less to have that modularity and configurability. Thanks for your responses. So market development, this is tough. We're creating a new industry in modular HIT technology. So we're bringing together companies that believe in that and are willing to put some blood, sweat, and tears and dollars into helping grow that market. We're also advocates to help influence policy as it's evolving very rapidly. And we're also on track to develop new services that will support companies in the clinical groupware space. We have a pretty darn diverse group of members. I think we're up to 50 companies now or thereabouts, and they range from very large enterprise type systems. McKesson is a member, Intel's a member, to middleware vendors, folks like Covisint that have this platform, EHR technology companies, providers and provider organizations. The American Medical Association is a member of the Clinical Groupware Collaborative. And we have a lot of innovative companies that range from very early stage to very sophisticated, larger companies that have a real knack for innovation. So it's a diverse group, and I've got to tell you, a very exciting group. We have some discussions with some of the great minds in this arena that are just stimulating to be involved in. And that's another one of the benefits we never talk about, but we have discussions truly with some of the thought leaders in the industry that just the intelligence you get out of being part of those discussions is invaluable. So examples of advocacy, we were recruited into InHIN Direct and have heavily participated in that.